So we're talking a little bit about head trauma here. You got this x-ray before you. I don't know why you would obtain that right now, but there you go. There's obviously depressed skull fracture fragments, and so the big concern with that is seizures, and if that's an open wound, those elements need to be elevated. They're more than a bone table width down. And here's obviously a terrible skull fracture, massive head injury. That's probably a post-mortem x-ray. That's sort of the Humpty Dumpty image. All the king's horses and all the king's men. Can't put that back together. Let's talk about basilar skull fractures. Questions abound on this because it's a clinical diagnosis more than a radiographic diagnosis. So you're expected to know the clinical findings of a basilar skull fracture. Remember, a lot of cranial nerves exit the skull, so cranial nerve findings should make you worry about a basilar skull fracture. So any of those deficits that are listed there. A CSF leak, most of those will resolve spontaneously, but they're a sure sign of a basilar skull fracture, whether it's CSF coming out the nose or out the ear. And they may ask about how do you know it's CSF with the migration on a filter paper or sheet where you see the blood migrate to the exterior side, the ring sign. Prophylactic antibiotics, the literature on this is really messy and mixed, but most centers now, neurosurgeons, have stopped giving prophylactic antibiotics, and the reason is what happens is it kills off normal flora and nasty stuff overgrows. So the prophylactic antibiotics don't prevent infection, they might select for worse infection, in fact. Remember that with many basilar skull fractures, even the head CT will be negative, and that's why we focus on the clinical diagnosis, looking for battle sign, looking for hemotympanum, looking for raccoon eyes with tarsal plate sparing. All of those are findings, clinical findings of basilar skull fracture. Some of them take some time to develop. You might see a person shortly after their injury, their head injury, and they don't have a battle sign or a hemotympanum. The hemotympanum might develop over the next hour or two, and the battle sign might take anywhere from 6 to 24 hours to sort of emerge. And so those findings might require reevaluations. Error in the posterior fossa on a CT scan usually is from a fracture line going through the mastoid air cells. And so that's a CT finding of a posterior of a basilar skull fracture going through the mastoid air cells. And so you might see that as well. You might even see a little air around the TMJ. That's when the air goes anteriorly from the mastoid air cells. You see a little bit on the CT and around the TMJ head. And then the ring test we touched on. There's hemotympanum and battle sign, clinical findings of a basilar skull fracture. Again, often radiographically negative, so the clinical findings are what lead you to the diagnosis. Even in a normal CT scan, you should make the call. Epidural hematomas, the arterial bleed, usually, not always, but the classic is the middle meningeal artery. The underlying primary brain injury, mild, they might have an immediate loss of consciousness, and then a lucid interval. These are the classic descriptions. Having noted that, I suspect everyone in here has seen a lucid interval with a subdural. Certainly can happen. The ipsilateral pupil dilates 85% of the time due to downward pressure and then compression of cranial nerve 3. Remember that the dilation of that pupil requires progression of the mass lesion till it presses down. Note that 85% of the time it's ipsilateral. That means that 1 in 7 it's not. So those are called false lateralizing findings. It happens because of a phenomenon called Kernahan's notch, whereas the mass enlarges rather than pushing straight down on the peduncle on that side and hitting cranial nerve 3, the pressures go up over the top and press down on the opposite side. That's why when you hear these stories about drilling a burr hole in the absence of a CT in some rural, desperate environment, 1 in 7 times you're drilling that burr hole on the wrong side. That's a bummer. And what would you do if you had that? They currently would recommend you drill another burr hole on the side of the dilated pupil before you abandon that and go to the other side. The classic appearance of an epidural is it's biconcave or lens-shaped, and it shouldn't cross suture lines. And so here's a drawing of an epidural hematoma. Notice that it's a coup injury. This would be associated maybe with a skull fracture and a middle meningeal artery. And you can see in this drawing that their midline is a little bit shifted. The thing I found most curious about this drawing is the lower area of this. I was giving this lecture a couple of years before I started asking myself, what are the fallopian tubes and uterus doing in this young man's brain? But if you ask women around the world, they'll tell you they know a lot of men that have this on the brain. at all times. And it may, in fact, have led to his head injury. Here you see epidural hematomas, biconcave, lens shape, midline shift. Subdurals, now venous usually, but not always. So this venous and arterial differentiation between these is by no means rigid, but it is sort of 80% in each case. Elderly and alcoholics at increased risk, we already talked about why. They're more common, and you should understand that there's much worse outcomes with subdurals. Partly because there's more primary brain injury than in an epidural, but also because of the populations that tend to get subdurals. They're elderly, they're alcoholic, they have piss-poor protoplasm, poorly put together. There's much more likely to be a delay in imaging. There's delayed presentations in this group. And so the subdural, which is the venous bleed, which doesn't sound as bad as the arterial bleed, is actually worse. More primary brain, more delays, and in a worse patient population, so 6 times the mortality. They are crescent-shaped, and the bottom of this slide is really important where they talk about the 3 types. They can be acute, which is white on the CT, subacute, which is isodense, that happens about a week out, and then chronic, where they turn black on a CT and sometimes are referred to as cystic hygromas. They can cross suture lines because they're subdural in anatomic location. And here we see a contra-coup, crescentric, moon-shaped lesion on the opposite side of the impact. And in subdurals, they're a lot trickier in terms of deciding when to intervene surgically. So the imaging alone doesn't tell you. And that's why, for those of you who have become rock uranium fans, I'm talking to the younger members of the audience for their RSIs that like to say, give me the rock. The problem with rock uranium at 1.2 per kilo is you deny your neurosurgeon an exam for an hour and a half. And so I'm an old school, ongoing believer that in general, SUX is still the drug of choice for RSI, because how many of you have been surprised by the presence of a subdural? It happens not infrequently in the emergency room, and I really want the neurosurgeon to have an exam available to them. There's a big subdural with shift and probable herniation. That person's crossing suture lines with lots of primary brain injury that, despite surgical intervention, might do terrible. There are 3 herniation syndromes. I don't find them particularly that useful to me clinically, because when someone herniates, it's kind of the sound I hear in my head is sort of the pinball machine sound. Game over. So I don't really care how the game ended, because for me, I'm an emergency physician. The game is over. But to know them, there's the central herniation, which is cranial nerve 6 palsy. So they can't look down and out. Remember, cranial nerve 6, your cheating muscles, down and out. Tonsillar herniation, which is the cerebellar tonsils push through and give you a respiratory arrest. And then the most common one, which is transtentorial herniation, where you get the ipsilateral dilated pupil 85% of the time. Remember, Kernahan's notch, 15% false lateralizing. And brainstem compression causes coma. Intubate if the GCS is less than 8. I've already talked about that. Elevate the head of the bed. People forget this. Elevating the head of the bed does as much for intracranial pressure as all the other things that we do. And it's not straight up, and it's not, empirically it's around 25 to 30 degrees gives the biggest decrease. Make sure that the collar and maybe if they're intubated, that the ties for the intubation aren't preventing venous drainage, which is very superficial in the neck. And so getting the head, if you come into a room with someone with a subdural, it's not uncommon to get in the room and see them like this. Well, you're preventing venous drainage on half of the head. So that's not going to do good things for intracranial pressure. So elevating the head of bed is as good as Lasix, as good as mannitol, and keeping the head in neutral position equally important. Now, if you're going to do other things, you'll hyperventilate them. Many of you are old enough to remember the days we hyperventilated them to a PCO2 of 20 to 25. And then we found out that when you do that aggressive of hyperventilation, what you cause is regional oligemia in other parts of the brain that might be normal. In other words, you potentially stroke out normal brain. So we said back off, and it was like a poker game. So initially it was 20 to 25, then it was 25, I'll see that, and raise it to 25 to 30, and then it became 30 to 35, which is almost normal. So if you have an intubated head trauma patient and you're hyperventilating them, you really need blood gases to find out where you're at, because you don't want to hyperventilate them too much anymore. If you're going to give mannitol, it's an osmotic diuretic, 1 gram per kilo, 1 gram per kilo. The lowest effective dose is around 1/4 gram per kilo if you're going to try and back off and save some later osmotic interventions. Controversial in children. Many pediatric neurosurgeons don't like the mannitol because it's a bit of a fluid challenge. And because of the cerebral edema injury patterns that children get, the fear is that the mannitol will distribute into the injured brain and increase swelling. And since cerebral edema is such a prominent concern there, many neurosurgeons for kids don't like mannitol. And so if you were going to give it, they might ask for 1/4 gram per kilo, and to make sure you give it as slow as possible so you're not causing a fluid challenge effect. Steroids are not beneficial. This has been looked at numerous times. They're not beneficial in spinal injury either. Remember, we had that whole thing with the Bracken studies, and we did steroids in spinal. Over time, we learned that steroids just don't help neurotrauma. And although Bracken didn't believe it, when you looked at the Bracken papers with clarity of analysis, he found that, in fact, there were a lot of complications of steroids: pneumonia, GI bleeds, other things associated with giving these injured, critically ill patients steroids. What was on the bottom of that? Again, the Monroe-Cully hypothesis down the bottom. What are you doing about intracranial pressure? Traumatic seizures, they come in a couple different varieties. So when you have a high fever and your kid gets a temperature really rapidly and they seize, what does it mean? It means the temperature went up really rapidly. Do they get treated for seizures? No. It's a consequence of the rapid temperature rise. The same, if you have a head trauma, you get whacked in the head, and as you're going to the ground, you get an immediate post-traumatic seizure, what does it mean? It means you were whacked in the head. They don't get treated. But if you have seizures an hour later or 6 months later, both of those get treated. So your delayed seizures happen and are important, but the immediate post-traumatic seizure does not get treated. How do we treat them? Dilantin or Keppra. There was for many years no evidence that Keppra was adequate for this, but finally over the last 5 or 6 years there's been some studies looking at Keppra, and it works just as well as Dilantin. So the Keppra is now proven right. For years we just did it because it seemed easier. What causes delayed post-traumatic seizures? You'll see it with bleeds. Subarachnoid hemorrhages are at greater risk. Remember, this is about cortical irritation. It can happen with fractures that are depressed even a little bit. Most occur within the first year, and the treatment is as you'd expect. Peds trauma, I've touched on it. Poor pressure volume curve. They get a lot of edema. The pressure goes up. And in the pediatric skull, there's not much things you can displace out of it. So in an adult, we have a lot of venous blood and a lot of CSF in our head. And as we get older, we have even more CSF in our head. And so as the mass lesion occurs, you can displace the CSF, so there's no rise in pressure. Then you can displace the venous blood with no rise in pressure. And eventually, once you've done those things, the ICP starts going up. With kids, the ICP goes up immediately. There's no delay. They don't have CSF reserves to displace or large venous intracranial reserves to displace. So kids, in addition to tending to have cerebral edema and edema-type injuries like diffuse axonal shear and malignant cerebral edema, they also have no place to deal with that pressure, so the pressure causes worse outcomes early on. They have, as I've said a bunch of times, these non-surgical lesions listed here. GCS in kids may wax and wane. Many of you have probably been just about to intubate a kid who dropped their GCS sort of precipitously during your initial eval, and then you went back in the room to do the RSI, and they're back to a GCS at 13. So you can see that waxing and waning GCS in kids. That is the malignant cerebral edema pattern, and it's pretty commonly seen, and you have to use your judgment about when you're going to pull the trigger to intubate them, as opposed to adults that tend to trend their GCS one way or the other. They're either getting better or getting worse. Remember, in kids, their skull's weaker, they transmit more forces, they might have open fontanelles, and so their skull is generally more vulnerable to blunt head trauma, and particularly the younger they are. So children less than 2, and particularly under 6 months, are increased risk. Skulls are thinner, as mentioned. Skull fracture increases risk for an intracranial injury by somewhere between 4 and 20-fold. Scalp hematomas can disguise fractures, and that's why big scalp hematomas are an indication for imaging. And persistent nausea and vomiting or delayed nausea and vomiting are all signs of rising intracranial pressure that ought to get imaging and neurosurgical consultation. Intracranial injury associated with minor mechanisms in kids, again, their skulls are weak, so minor falls and things like that can do it. Growing fractures, that red arrow is on a fracture that is now, this is like 4 months after the injury or 6 months after the injury. You can see the fracture lines are like 2.5, 3 centimeters apart. That's a growing skull fracture. It happens with immature skulls. It's called a leptomeningeal cyst, and it's an excellent thing to ask questions on. And it's why pediatric skull fractures, even though they might be uncomplicated when seen initially, all need delayed follow-up 4 or 6 months to see if they're developing this well-known, although not that common, complication of fracture in kids, which is a growing fracture. Concussion for both peds and adults. What does it mean? It means you had some change in neurologic function. Do you have to have lost consciousness? No. Loss of consciousness tells you that they're concussed, but you could have no loss of consciousness but still have problems with, anytime someone's asking you 3 times after their incident, they didn't lose consciousness, but they're asking you, where's my wallet, or where's my family, what happened to my car? They ask it the second time, they're obviously not processing new information, so they have abnormal CNS function. That's a concussion. There's been some recent papers talking about our failure to diagnose, a sort of doctor bashing papers on emergency medicine, reminding you that when you find concussion, you shouldn't just call it blunt head trauma. You should be diagnosis 1, blunt head trauma. Diagnosis 2, scalp laceration or scalp hematoma. Diagnosis 3, concussion. The concussion really means they ought to be referred. These kids are symptomatic for months afterwards. So up to a third of them symptomatic at a month. And so the concussion is the most significant part of their diagnosis, and they should have referral and graduated return to play. And you know, if you're lucky enough to have a traumatic brain injury clinic, they should be referred there. Post-concussive syndrome, commonly asked about post-concussive syndrome. Someone comes in, they had negative imaging initially, now they're 3 days out, and they're having these ongoing problems with concentration, can't sleep, irritability, mood. So there's both sort of the sort of hard findings, nausea, vomit, other things like that, and then the neuropsych sort of things, mood, inability to concentrate. That's post-concussive syndrome. On the question, they cannot float a hard neuro finding. There are no hard neuro findings in post-concussive syndrome. So if they write a question that sounds like post-concussive syndrome and they try and slip a hard neuro finding in, the most common one that they like to slip in when we write questions, the Royal Examining We, is ataxia. That is not post-concussive syndrome. That's something else. And then second impact syndrome is about clot resorption. Remember, there are a lot of questions and situations in emergency medicine. When someone has a small hyphema, when do they rebleed and get an 8-ball hyphema? Like 5 to 7 days out during clot resorption and retraction. If someone has a labial artery bleed, when do they rebleed and come in with that labial artery squirter? 5 to 7 days as they reabsorb clot. And the same, if you had microbleeds in your head, which we don't know about because we don't MRI all these kids, right? You need MRI to find these microbleeds. 5 to 7 days later is when they're maximum risk for second impact syndrome. And when it happens, the outcomes suck. They're devastating. And so for me, any kid who's playing sports, who's brought to me with their bell rung and gets a head CT and all of that, the question will come, can they play hockey next Saturday when the scouts will be there? The answer is no. Not until a neurologist or a pediatric specialist clears them. And some people say, oh, you're being too conservative with that. No, I'm not playing the second impact syndrome game at all. So for me, the answer on all of those is no. All right, penetrating neck injuries. That's Slash from Guns N' Roses. It turns out that between your head and your body, there's this area, it's called the neck. And in the neck, once you get through the skin, everything in there is really important. There's big red things, there's big blue things, there's breathing things, there's aerodigestive tract, there's esophagus. There's nothing in there that really isn't important. So any injury that goes through the platysma needs worked up. If it penetrates the platysma, it gets worked up. Now in the old days, this was really complicated, which should take place, and da-da-da-da. But now it's all pretty much resolved. They need a CTA. The CT will show most of the injuries. You got to get the A part. You're looking for vascular problems. Vascular problems are the biggest issue. Most of them, about 80%, are in zone 2. You got to know the zones of the neck. We'll go over the zones of the neck in a minute. If they're in zone 2 and they have bleeding, they could go to the OR. And the reason a zone 2 injury can go to the OR is any vascular surgeon will tell you that if you're going to operate on blood vessels, and particularly arteries, to do that surgery, you need proximal control and you need distal control so that you can put that thing together and get a bloodless field. The problem is, in zone 3, distal control is either behind the mandible or in the head. That's a little inconvenient. The problem with zone 1 is proximal control might be inside the chest. That's super inconvenient. And so for zone 1 and zone 3, you really need to anatomically define the injury before you go to the OR to know what you need to do in the OR and who needs to be there. Zone 2, though, technically, although very rarely do surgeons take even zone 2 injuries directly to the OR, but theoretically you can because you can achieve proximal and distal control. Someone's got a slash wound to the neck, a lot of venous bleeding, and you listen to their heart and you hear a machinery murmur. What does that mean? It means they sucked air in through that wound into their heart. Machinery murmur is code for air embolus, air in the right ventricle. What should you do? Put them in left lateral Trendelenburg position to try and trap those air bubbles in the apical of the right ventricle away from the outflow tract. And if they have a PFO or something like that, those bubbles might get to the other side of your circulation and cause bubble emboli. All right, this slide is important because I know that 99% of the time in emergency medicine, when we talk about stridor, is that a good thing or a bad thing? It's bad. When we talk about, things like vocal cord paralysis, hoarseness, good things or bad things? Those are bad. So look at this slide where you have the hard and the soft signs. It's relatively counterintuitive that stridor, hoarseness, and vocal cord paralysis with subcutaneous air are all on the soft side of neck injuries, which means they can be worked up with a CTA. Hard signs, which if they're in zone 2 are the things that get you to the OR, are hypotension, arterial bleeding, expanding hematoma, thrill, bruit. Remember that if someone had a pencil in their mouth or things like that, and they have penetrating neck trauma in the mouth, what's right behind your posterior tonsillar pillar? The carotid. So if they have a hematoma in there or anything there, remember thinking about that as a zone 2 neck injury, right? Vascular injury. So remember those. I remember I was intubating this guy at a small community hospital. He was brought to me for airway control instead of the trauma center, as happens, because he had all this bleeding on the scene, and he had an intraoral injury. And I remember as I went to intubate him, there was like a clot dangling right behind his tonsillar pillar, and I was like, oh, let's get by that. And we did get by that, but we were resuscitating him, and so his pressure came up, and he just started bleeding like stink. And we put the Yankauer in there, funk, there's 1.5 liters of blood. Give me the other one. Funk, there's 3 liters. And then he arrested, and I was like, well, there you have it. You know how you ask when you're doing a resuscitation? Anyone have any other suggestions? The question was, how do we get that into that? But, so these vascular injuries obviously are immediate threats to life. Most of the time you get told it's a carotid bleeder. You hear this, oh, carotid bleeder. They're usually venous, except for when they're not. Here's the zones of the neck, zone 1, zone 2, zone 3. The workup now, it's all simplified. The bottom half of that slide has all gone away. It's CTA. Here's your zone 1, zone 2, zone 3. Completely fair question. They might ask it. Zone 2, the most common, the biggest territory, the area where most neck injuries happen. Now we'll talk about blunt neck trauma. Obviously, we're working about broken necks. We'll talk about that in ortho. We're worried about anterior, the hanger. Someone hangs themselves. What do they need? CTA of the neck, but they also might need endoscopy because endoscopy and CTA are complementary. You'll be able to see edema and topical injuries when you do the endoscopy, so they might need both. Seatbelt sign to the neck. Recently, we've been finding more of those as people slide under, they submarine, and so the shoulder harness rides up, gets their neck, and they have bruising and stuff. And they might be neurologically intact. The injury you're worried about is a flap in their carotid. And those flaps, all of those flaps, whether they happen in the vertebral artery with chiropractic maneuvers, or with sneezing, or in the carotid with this kind of mechanism, they often present neurologically intact because the flap allows intermittent flow. They may have said at the time of the incident, right at the scene of the accident, I had numbness. You got to ask, what do you mean by numbness? If they just say I was dazed and, confused, that's different. If they say I couldn't move the right-hand side of my body, then you need to work that up for a vascular injury and get the CTA. Here's a flap with a pupil and a Horner syndrome from blunt neck trauma. And you can see the filling defect. It's not complete. The vessels distally are imaged, but if you look at this literature, it's kind of scary literature when you look at these blunt neck injuries. They often don't have their permanent neurologic deficits till 4 or 5 days later. So you can easily see how the initial evaluating physician might be sort of lulled to sleep on it. Obviously, in emergency medicine, if they're asking questions about this, they don't want you to be lulled to sleep. They want you to get the imaging. Chest trauma, thoracic trauma, about a quarter of all deaths. A lot of those are penetrating. And we have these two bullets here that are kind of worth knowing. If you have hypotension, just general, you're a trauma patient with hypotension, and it's blunt trauma, what is the source of the hypotension? Pelvic fractures with retroperitoneal bleedings, number one. Intra-abdominal injuries, liver, spleen, etc., number two. And intrathoracic is number three. If you have hypotension with penetrating trauma, it's lung greater than heart, greater than great vessels. So lungs are the biggest thing. That's why they're going to be number one. And, pulmonary artery bleeding is pretty impressive. Open sucking chest wound, put an occlusive dressing on it, and if it causes a tension pneumothorax, make sure it's vented and can breathe. Needle thoracostomy, we've already touched on. Second intercostal space, mid-clavicular line is the correct answer. But if they offered you the fifth intercostal space at the mid-axillary line, there have been a bunch of research done on this. Kenji Inaba and others at LA County and some of the people in the military have done some of these. And we now know that that's much more likely to be successful. As Americans have gotten fatter and bigger, there's a good chance with an 1.25 inch catheter plunged into the second intercostal space, you won't reach anything. You won't reach anything. So if they offered you the fifth intercostal space, mid or anterior axillary line, that's good. Sucking chest wound, here you can see the air going in. It may or may not get out. You put the dressing on. We've already talked about open thoracotomy. If you had a stab wound to the heart, what's the most likely to be injured? The right ventricle is true anterior. That's what lies below the sternum. So right ventricle is the most likely. Right atrium also, depending on how high it is, and then other structures. And so you want to look for those, and you crack. I love finding a stab wound to the, after you skin the heart, there's something in the right ventricle. Why is that so wonderful? Because it doesn't bleed as much as the left ventricle, because it's lower pressure circulation, and the right ventricle takes staples beautifully. There you have it. I've had people wake up after having a staple placed because they suddenly had return of pressures and stuff. Then you're like, we should sedate them and intubate them, because they're often not even intubated yet. All right, rib fractures, it's a clinical diagnosis. And so people with a lot of rib cage pain, even if the films are negative, just tell them they have a rib fracture. You want to get a AP chest x-ray or a PA chest because you're looking for pneumothorax, pulmonary contusion, and vascular injuries. Those are the more important things. If they have multiple rib fractures, you're worried about abnormal breathing mechanics and things like that. Admit the elderly or people with pre-existing pulmonary disease, COPD, bad asthma, those kinds of things, because they're going to have complications. They might get pneumonias because they can't ventilate. And if you do send someone home, they should probably go home with an incentive spirometer and those types of things, indicating your recognition of this. Scapular fractures, let's talk about those. Scapular fractures haven't changed in 30 years of trauma care. If you have a scapular fracture, you have a 1 in 10 chance of going to the morgue. Obviously not from the scapular fracture. So scapular fractures are markers of major hemithoracic or transthoracic trauma. It's really hard to break a scapula, right? It's like a discus ensconced in muscle, both above and below. And so if they have that fracture, you ought to worry that that whole side of the chest has been crunched pretty good. And so they're at risk for pulmonary contusions, intrathoracic injuries, even abdominal injuries. And so 10% mortality. First and second rib fractures. Many of you are old enough to remember the days where everyone with a first or second rib fracture, everyone got admitted for a classical aortogram. And we found that that aortogram was really low yield. So in the absence of physical findings, first and second rib fractures don't require anything other than the CT that you've done. But they are markers of more mortality. And so high rib fractures and sternal fractures are both things that should get your attention. You want to rule out myocardial contusion, bronchial tears, and vascular injuries. And it's going to be a CT with contrast as the workup. Flail chest, segmental fractures, 3 or more with abnormal mechanics, paradoxical chest wall movement. What do you want to do? Direct pressure, intubate, consider a chest tube. The main cause of hypoxia is an oft-asked question. It's not the failure to ventilate or the abnormal mechanics. It's the underlying pulmonary contusion, which impacts a large proportion of the lung tissue on the affected side. Sternal fractures, Yes, they can be bad. There can be myocardial contusions, but the vast majority of sternal fractures are actually isolated injuries, and they can go home. They can go home. You should have worked them up. You should get an EKG. You should look for things. Do you need to get a troponin looking for blunt cardiac injury? Depends on the trauma surgeon you ask, but in ATLS, the answer is no. We know the heart might be bruised, so a troponin is not useful. Positive troponin doesn't tell you anything new. Unlike in ischemic heart disease, where the positive troponin may indicate other things that need to be done, revascularization, an angiogram, a stent, those kinds of things. So understand the difference between a positive troponin in ischemic heart disease and a positive troponin in trauma. A positive troponin in trauma is not very useful. It doesn't portend future complications. More about flail chest. You can see the big pulmonary contusion on this, right? There's black lung on one side, a lot of gray lung on the other. And so there's a big pulmonary contusion. Pulmonary contusions have interstitial edema and bleeding and capillary leak. They may cough up blood, not a large volume of blood, even just some pink stained sputum or streaked stuff when you're cleaning them out through the endotracheal tube tells you what's going on. They may have decreased compliance, hypoxia, and atelectasis. If they ask you questions about how much fluids do you want to give in this situation, you want to give less because the crystalloid's going to redistribute into the pulmonary contusion area. And the x-ray findings can be all over the dartboard, and they can be delayed. So you might re-chest x-ray someone 4 or 6 hours out, seeing how bad or whether this is progressive. And there it is, the bullet down there. Aggressive fluid resuscitation, particularly with crystalloids, isn't going to help this. It's going to make it worse. Worse than their ARDS, their post-traumatic ARDS that's going to follow down the road. Here's someone who's got a pulmonary contusion that's patchy and very well localized, and if you look a little more carefully, you see there's a bullet right in the middle of their mediastinum, perfectly oriented vertically. Where is that bullet? There's only one thing. I've been doing trauma for a long time. That's in the spinal column. So I expect this person to have a T4 level, and that pulmonary contusion is due to the cavitary forces of the bullet as it transverses the lung, and that may get a lot worse over time. All right, tracheal bronchial injury, not often seen except on exams because it lends itself to questions so beautifully. High mortality with these ruptures. They can happen with blunt injury, and when they do, they happen within 2 centimeters of the carina. A beautiful anatomic question, either just proximal or just distal to the carina. That's where they occur. When they happen and you put a chest tube in, the chest tube will continue bubbling and reflect an air leak. That's a beautiful question. And the signs and symptoms, chest pain, dyspnea, hypoxia. Oh, and that beautiful Hammond's crunch. That's not a Nestle's crunch, that's a Hammond's crunch. Hammond's crunch symbolizes air in the upper mediastinum. And the difference between that and a pleural friction rub is the pleural friction rub follows the respiratory cycle as opposed to a Hammond's crunch, which follows the cardiac cycle, because it's the heart beating that's making the crunching. And so this slide, they love these questions about tracheal bronchial injuries due to the air leak, the bubbling chest tube, the anatomy. All of that lends itself to Hammond's crunch. Just beautiful stuff for question writing. Hemothoraces, you've all seen them and managed them. Decreased breath sounds, dullness, percussion. On a supine film, they can be sneaky, right? Because they layer out. It might just be a little bit of shadiness on one side. Beware a right mainstem intubation, which can mimic this, right? You can get sort of haziness on one side if you do a right mainstem intubation, and it would be a bummer to get a chest tube rather than pull back the endotracheal tube. Diagnosis, chest x-ray, ultrasound, CT. Most of these people are going to be getting pan CTs if it's from significant blunt trauma, but you can find them very early on ultrasound, and there might be questions about that mechanism, although they do not on the recert exam, at least last I checked, there are no ultrasound images there. But if, for the primary cert exam, you might see them. How many primary certers are there in here? Just going for it first time. There's got to be some of you in here just finished. There you go. Thoracotomy indications, we already talked about it, 1,500, 100 per hour for 6 hours, persistent air leak, all these things tell you there's something bad that needs to be fixed surgically. Here you see an upright chest x-ray with a hemothorax on the right. See how it's the costophrenic angle is squared off. You can hide about 250 cc's posteriorly in an upright film, so that's 250, 300 cc's there. And here you see a CT scan. And CT scan, it's really easy to underestimate the size of a pneumothorax on plain films. When you get the CTs, they can really shock you as to how much larger they are when you can actually see. And here you see this X-ray with the hematoma, and look how big the pneumothorax is. It looks way bigger than it is on the plain film. Pneumothorax, chest pain, dyspnea, sub-Q emphysema. Chest X-ray findings can be delayed for many places. If you have a stab wound to the chest and your initial workup's negative, what do? You get a delayed chest X-ray at 4 to 6 hours. You'd like that chest X-ray to be end expiration. That's the most sensitive. They ask questions about that occasionally. Why at end expiration is the chest X-ray more sensitive? Because the pneumothorax volume is the same, but the lung volume is less because you expired. So the relative volume of the pneumothorax is increased. Plus, the lung tissue at end expiration is denser, so there's greater contrast between the lung tissue and the pneumothorax, so you're more likely to see it. Tension pneumothorax, severe dyspnea, decreased breath sounds. Don't wait for the X-ray, they always say. Everyone in here has seen an X-ray with a tension pneumothorax, so we know that that axiom can't be correct. So there are many patients who, the rate at which your tension develops, you might be hemodynamically quasi-normal, and a chest X-ray would be totally appropriate. And that's why we've all seen them, because you'd like to define the anatomy before you put the garden hose in their chest. So that's why almost everyone in here has seen one of these, because they were holding their pressure for a while before you did it. But if they're hypotensive, if they give you hypotension with absence of breath sounds, yeah, put in a chest tube before you do an X-ray, for sure. And here's a normal pneumothorax as opposed to the tension pneumothorax. See how the tension pneumothorax pushes the medium sternum over and kinks off the garden hoses that are returning blood to the heart. So the SVC and the IVC get collapsed, and if there's no blood return to the heart, no venous return means no cardiac output. And that's why if you decompress that chest and let the heart move back to the middle, they'll get prompt, immediate return of vital signs, because you'll suddenly restore venous return. Just another picture of the same thing of how this happens. Pneumomediastinum, the yellow air, shows an air stripe in the prevertebral soft tissues going vertically. And you can see them laterally on an AP as well. And you might have the Hammond sign again, because there's air in the mediastinum. In the superior portion of the mediastinum, it'll give you a Hammond's crunch. And this can happen with mechanical ventilation, with Valsalva, with sneezing, with ruptured blebs, and it can be pretty impressive. Sneezing, deadly, deadly. These are all things that I've seen from people sneezing. I've seen someone sneeze who had a vertebral artery dissection from sneezing. I've seen someone who destroyed their neurosurgical approach to their pituitary tumor, and they had tension pneumocranium from sneezing. And finally, I saw a guy who he had no ear, he had like something over here. And he went to the House Institute, which is like the Mass Eye and Ear in California. And they said, all right, we're going to build you a beautiful ear, you're going to love it, you're going to get hot dates, the whole thing. But first they had to bring a flap of tissue up there, and it was the vascular flap wasn't long enough, so they stented something off his external carotid, so he had this pulsatile mass on the side of his head. They said, don't worry, we're going to make an ear out of that. It's going to be great. It's going to be great. He's at an Italian restaurant. Would you like some pepper on that, Caesar? And what happened when he sneezed? He didn't let it go. Massive intravascular pressurized, and the fucking thing blew up. Everyone around him got extra sauce. And they brought him in, code 3. I was at, in fact, there's some people here who work at that same place, saying, uncontrollable airway. But I'm like, should be going to a trauma center. Carotid. Anyway, they bring him to us, and the medics are strangling him. His head looks like a Pinot Noir grape. They bring him in. I'm like, what are you doing? Like, let go of him. They go, strangle him. And, so we're working him up. And I love when the vascular surgeon came down. The vascular surgeon, and she was, responded promptly, great vascular surgeon, but you know how surgeons are a little abrupt. She looked at me like I was to blame for that thing on his head. She looked at me, and I'm just quoting her. Rick doesn't like the profanity. She goes, what the fuck is that on the side of his head? Like, me, like, I put it there. I'm like, I don't know what it is. She says, I'm fucking tying it off. I'm like, it's whatever you do. I mean, he's bleeding a lot, so whatever you think. So they had to start all over at the Mass Eye and Ear. at the House Institute in California to rebuild them. But anyway, you'll see these air. So sneezing, my rule, let it go. You feel a sneeze coming, spray. Don't hold it in. Don't hold it in. Here you see the paramedian stripe on the airway. It's another pneumomediastinum. Diaphragmatic traumatic injuries. So diaphragmatic injuries, a lot of the literature on this is written from trauma registries where they mix, like in a blender, the blunt and the penetrating, and so they mix you up. But we have the next slide that's going to straighten it out. They're sneaky, they're hard to diagnose, they're often delayed, but the distribution and the nature of blunt and penetrating injuries is very different. Nothing is good to diagnose these. CT isn't good. Ultrasound isn't good. X-rays aren't good. So you have to do basically you have to lay the surgical retina on the underside of the diaphragm, either through a thoracoscope or through an abdominal laparotomy scope. You got to look, and then you can go after it. But they get missed. But they're quite different, so we'll go through it. Here's the money slide. If you remember this, you'll have it. Blunt. Now, who are you picturing here? Picture a fat truck driver. Why a fat truck driver? Because the big belly and the horizontal steering wheel of a truck. So that's going to hit the belly and cause a massive surge in intra-abdominal pressure. That massive surge is going to tear the diaphragm, and it's going to tear the diaphragm on the left more than the right because the liver protects the right side. Having noted that, it's not as much as you might think. So underneath left and right, I would put 60% and 39%, which is a reminder that 1% of the time there's enough pressure to tear both sides. The tear is going to be in the anterior part of the diaphragm, and it's going to be a big tear, 6 to 10 centimeters. The diagnosis is going to be delayed. If you expect to see the NG tube coiled in the stomach and the chest, that's when there's translocation of the stomach into the chest. That only happens about half the time. So if that's the only time you find these diaphragmatic injuries, you're going to miss half of them. Translocation happens about half the time. The chest X-ray is frequently abnormal but non-diagnostic. Now, go to the other side. Penetrating injuries. Think skinny jerk-off. Why do I say the person stabbed is a jerk-off? Because most stabbings, both people are jerks. Now, there's the stabber who's right-handed. Stabbing is an intimate face-to-face thing. So when the right-handed guy stabs the other person who gets in his face, where's the injury going to be? It's going to be on the left greater than the right. Now, the gunshot wounds to the chest in terms of diaphragmatic injuries, they don't lateralize at all. All you got to do is watch an episode of Cops. The guy empties a whole clip as the guy runs away from 6 feet away. What does he hit? Nothing. Nothing. Handguns are all, they're all over the dartboard. But the stab wounds tend to be on the left. So it's 60% left, 40% right. They tend to be thin, and the wound will go into the person's left flank. How low does the diaphragm go down posteriorly? It goes down a lot lower than many people appreciate, all the way down to L3. So it's possible to tag the diaphragm without even having a hemopneumothorax. And so you're going to miss that. You're going to get your delayed chest X-ray. It's going to be normal. And then over time, years of time, every time the person bears down to go to the bathroom or increases their intra-abdominal pressure because they're yelling, the rent's going to get a little bigger and a little bigger and a little bigger. And then 4 years later, they're going to translocate their stomach or their transverse colon into their chest. So the first one, the blunt one, is delayed diagnosis, but delayed like 12, 24, 36 hours. The second one is delayed diagnosis, years. I have argued successfully in court that the standard of care is to miss the injury. I'm very proud of that, and won that case. So here's the stomach and the chest with a big fat mediastinum and all kinds of, this person's got a massive hemothorax on that side. Stomach's in the chest, that's bad. All right, traumatic ruptured aorta, they love this too. Again, not very common. Many victims, about 85%, die at the scene. The other 15% used to come to the emergency room and die. But now some are surviving. Why so? Because they're putting vascular stents in these with some success. So in 2019, there's an increased number of survivors, so finding these early in your trauma workup has actually increased in importance because they'll stent them. They often have pre-existing vascular disease. They're older, they're stiffer, their ligamentum arteriosum is tied to their inner circle of their aorta, and if they're stiff and they have a decelerating injury, that's where the tear will occur, at the isthmus. Retrosternal pain, dyspnea, stridor, they might have a harsh murmur. All of those things should make you worry about an aortic injury. Let me do this for you. Here's the arch of the aorta over my head, the rainbow of the aorta. Here's ligamentum arteriosum attached to the inside edge of that arch. Traumatic aortic injuries start at the inside edge where that ligamentum arteriosum pulls off. So they start on the inside short radius of that arch and go across. As opposed to dissection, which comes from the jet stream over an aortic valve. And so they start on the outside edge, the big radius of that arch. So understand that anatomic difference. There are many chest x-ray findings of a traumatic ruptured aorta, left apical cap, blurred knob, the bottom of the slide, moving of the NG tube in the airway, and all of that stuff are there. But the one they love to ask questions about is the left apical cap, shown by those 3 small arrows, because there's not much else that does that. They might have first and second rib fractures and all the other things that are associated possibly with aortic injuries. Here's this is bad, right? You got a wide mediastinum. Is there any aortic knob in there? No, it's blurred out completely. The mediastinum is completely indistinct. The trachea is pushed over. The mediastinum overall is wide. There's high rib fractures. There's a hemothorax on the left with a whiteout. And then there's that necklace that probably says, "Do not resuscitate," or something cheeky like that on it around his neck. So that's someone you'd want to worry about. A traumatic, you're going to put a chest tube in this. You're going to resuscitate this. You might be doing a massive transfusion protocol. And you're going to want a CTA on this as soon as possible. And if you've confirmed an aortic arch injury at ligamentum arteriosum at the isthmus, they're going to try and stent it. Here you see the arrow pointing to the outer edges of the traumatic aortic injury, but it started down where those dark lines merge on the inside edge where the ligamentum arteriosum is. REBOA. So resuscitative endovascular balloon occlusion of the aorta. Very new. If you go to any trauma conference, they spend a lot of time talking about ECMO and REBOA, things that probably most of you have not done or participated in. But there's been so much fuss about this, we added it to the lecture just so you could know. The catheter goes in, you occlude it in zone 1 for the heart, zone 2 for the belly, zone 3 for the pelvis. Since pelvis is the most common source of bleeding, right, we went over that in blunt trauma, what is the most likely zone that you would be asked about inflating? Zone 3. And here's just another algorithm showing the catheter going in and how you'd station it to occlude various levels. Cardiac tamponade, fun stuff to talk about. Beck's triad, hypotension, JVD, and muffled heart sounds. I always wondered about this because I always thought that all heart sounds were somewhat muffled. I was never that impressed with my stethoscope or auscultatory skills. But anyway, there you have Beck's triad. They might have pulsus paradoxus and electrical alternans shown there. Notice the alternating axis of the QRS. And it's often said that you'll see electrical alternans more in medical effusions like cancer and a big pericardial effusion. But you'll see it in trauma. I've seen it many times in a trauma patient with impending bloody tamponade. Treatment is pericardiocentesis. How many people believe you can suck blood clot out from around a heart by sticking a needle in it? No, you can't. You might try it if it was all you were offered, and you might get a small volume out, but it's clotted. Blood around the heart is almost always clotted. So it really needs to have a thoracotomy and the heart skinned and the clot relieved. So it's thoracotomy is what they really need. You could try pericardial. For the medical ones, pericardiocentesis is great. Put a pigtail catheter in there, do whatever you want. Myocardial contusion, a diagnosis looking for a reason to exist. Chest pain, they might have a sternal fracture. What EKG findings go with a stunned heart? Well, we talked about how the right ventricle is true anterior, so a new right bundle branch block, that would make me want to echo them. A lot of PVCs might make me want to echo them. A new first-degree AV block, because the SA node is sort of close to the sternum as well. So those are the EKG findings you'd look for. If troponins, as I said, not indicated, and most heal without specific treatment, and complications, as noted at the bottom, are quite rare. If they have abnormal vital signs or an abnormal EKG, they should be admitted and echoed. All right, more abdominal trauma. 2/3 of it is blunt, 1/3 is penetrating. The blunt is motor vehicle accidents and direct blows and falls, seatbelt injuries. If someone has a seatbelt sign, what does that mean? That means they're no matter how the seatbelt sign, even if it's just a faint pink lines, That means there's substantial risk for intra-abdominal injury. And so if the CT is done and it's negative, what does that mean? And they're having ongoing pain. It means they should be admitted and observed and followed because they might have a mesenteric bucket handle tear or an intestinal injury. And we all know that CT is great at positive organ injury, great at the spleen, great at the liver, great at the beans, great at retroperitoneal bleeds, but not so good at hollow viscus and pancreas, all which are at risk with this seatbelt injury. So a seatbelt injury with a negative CT and ongoing pain gets admitted. Laparotomy. Who needs to get a laparotomy? Well, if they're eviscerated or they got a gunshot wound or impalement, gross blood by NG or rectal, positive fast with instability. Notice it's positive fast with hypotension. That goes to the OR. Positive fast with normotensin. You have time to probably image it up, and most trauma surgeons would want to image it up before they went to the OR. Give me a high sign. Am I over? Because my clock's not on. 2 more minutes. I got some calls here. So here's a person with some penetrating abdominal trauma. Usually they come in with the intestines inside them. How did the intestines get outside them? I've seen this happen multiple times. A surgeon comes down, looks at the wound. Surgeons can't help themselves when they look at a wound. They snap on a purple glove. They don't talk to the patient. They stick their finger in there. The patient goes, "Whoa!" There you go. There you go. Take them to the OR. So yeah, if you stick your finger in there, they will reward you. Stab wounds to the anterior abdomen. The 1/3, 1/3, 1/3 rule applies. 1/3 of the time you get stabbed in the anterior abdomen. It goes through your skin, into the fat, and doesn't hit anything else. So what does that need? Wound care and maybe a stitch. 1/3 of the time it goes through the skin, through the fat, and through the peritoneum, but doesn't hit anything on the inside. What does that mean? A brief period of observation, some wound care, and maybe a stitch. And then finally, the last third, through the skin, through the fat, through the peritoneum, and tags an organ. That might need surgery. So 2/3 don't need much. And that's why many anterior abdominal stab wounds are observed. They'll get a CT scan, nothing found. They'll watch them, follow their vital signs. What's the optimal duration of observation? Not known. Now, because the diaphragm moves up and down, remember, nipple to navel is no man's land with penetrating trauma. The diaphragm moves up and down. So I got a gunshot wound right here. Here's the rule. Could be in the belly, could be in the chest because it's between the nipple and namen, could be in both, could be in neither. The most common failure is to recognize it could be in the belly. So someone comes in, gunshot wound here, they got a hemothorax, you put a chest tube in, everything looks good, there's high fives all around, no one dies unless I say so, then you turn around, the guy's hypotensive because it wasn't just in the chest, it tagged the liver too, and now they're bleeding. So remember, nipple to navel, could be in belly, could be in chest, could be in both, could be in neither. What's the neither about? We've all seen gunshot wounds that tract around the body and the subcutaneous tissue and stab wounds that don't go deep enough, etc. So that's the neither. Here's the no man's land nipple to navel, and we also worry about stuff that's in the box, which makes you worry about heart injuries. So anything in the box over here, that's your cardiac injury box. All right, abdominal trauma. What kind of imaging do they need? Going to get plain films? Oh yeah, KUB will help you out. No, we all know that's all over. So if you're worried about the belly, you're going to CT them up, and you're going to know that it's insensitive to hollow organ, pancreas, and diaphragmatic injuries. We've already talked about all that, which is why if they have a seatbelt sign and they're still having pain, they get admitted because they are a risk for hollow viscous injury. When do you do a CT or a cystourethrogram? Is if they have hematuria, gross hematuria in particular, you need to assess all of that, and if they have penetrating trauma, you really need to see the ureters. Nowadays, that can be done by CT. Ultrasound, we already talked about. You're looking for free fluid. On the recert exam, there are no ultrasound questions, but on other ones, if they ask an ultrasound question, it'll be really straightforward, like a big black wedge between the liver and the kidney, which is free fluid in Morrison's pouch. DPL, I'm not going to talk much about it because, again, many of the fourth-time reserters in here and some of the third-time reserters have done DPLs, but DPL is a procedure of historical significance only. The only reason you would consider doing a DPL is you don't have an ultrasound machine. And the reason is we don't care about the presence of blood in your belly anymore. There has to be enough blood. And so the DPL finds any blood. So way too many people would go to the OR if you use the DPL to determine it. We want to know how much blood is there. So we want to grade that either by CT or ultrasound or both. So DPL is really just out of the picture nowadays. There's some, I haven't seen questions about it in a long, long time, but there's the data on it if you want it. Now we have some other trauma things. Gray-Turner sign. What gives you Gray-Turner sign? Gray-Turner's 2 words, 2 flanks, bruising out on the sides. Happens with an ectopic, can happen with hemorrhagic pancreatitis, can happen with trauma, can happen in a post-cardiac cath patient. Why do they get it? Because someone aggressively puts that catheter into the retroperitoneum when they're entering down in the groin. So they get a big retroperitoneal hematoma. Kerr sign, left shoulder pain with a subdiaphragmatic irritation or a splenic rupture, right? C3, 4, and 5 keeps the diaphragm alive. Where's the dermatome for C3, 4, and 5? It's the shoulder. So if you have subdiaphragmatic injury from a spleen, it's going to hurt in your shoulder. If you have subdiaphragmatic pain on the right side, like with Fitzhugh-Curtis or something like that, you'll have right shoulder pain. Cullen sign. You look in the belly button, there's a Pinot Noir grape in there. There's blood down in the bottom of the belly button. That goes with anterior abdominal wall hematomas. You can see it in hemorrhagic pancreatitis. You can see it ectopic. The only case I ever saw with it was the flu. I'm not making it up. I was working at, again, same place with the pulsatile ear. And I had this guy who came in, he had the flu. He had a temperature 102. He was positive flu test. He had some underlying reactive airway disease, wheezed a lot. We were giving him inhalers. He was looking a little better. I was about to let him go, about to discharge him. All of us have had these questions where you're about to discharge somebody, went, something's not right. So I went to go discharge him, and he hadn't had an inhaler for like an hour and a half, and his heart rate was 140. Now, what's the heart rate you expect with the inhalers? You've all done this. They get a little tachycardic. It's like 120, 115, not 140. As I told you, 140 is the I'm bleeding to death number. So I went back, and he hadn't had one for a while, and he's like, heart rate 140. Shit, he's a big fat guy. I listened to his lungs. He's not wheezing anymore. I'm like, maybe we should undress him. So I'm taking the big Hawaiian shirt off. And I get down there to the belly button, and there in the bottom of the belly button is this purple thing. And I'm like, Jesus, what is that? So I ask him, like, is your belly button like purple in the bottom? He says to me, full irony and satire, I haven't seen it in a few years. Seemed fair enough. Anyway, so now I'm thinking, well, let's get some labs and stuff. So we get a line in him, we get some, his hemoglobin's 9. I'm like, I call him the scanner. Fortunately, he's just under the scanner weight limit. We get him in there, we scan him. He had a big 2-liter rectus abdominis sheath bleed because when he coughed from the flu, he had this big pannus. And every time he, the pannus would slam down and eventually ripped his rectus abdominis off his pubic surface. There was a big bleed there and a Cullen sign. So when I think of Cullen sign, I think of the flu. And then Rosving sign, there it is. This kid's got the flu and a seatbelt sign, so it's probably not that. But there's a little faint blush. Remember, it doesn't matter how bad the seatbelt sign is. Even a faint blush seatbelt sign means red alert. And in this kid with a faint blush seatbelt sign and a purple belly button, that's like a red alert times a red alert. There's Gray-Turner's spleen. I'll break here.